Hello and welcome. My name is Amy Vaughn. I'm a doctoral candidate with the University of the Cumberlands, and today I want to talk about trauma-focused interventions for PTSD for veterans. So there are about 18.5 million veterans living in the United States, and about 14% of Operation Iraqi Freedom, Operation Enduring Freedom, 12% of Gulf War, and 30% of Vietnam veterans experience PTSD within their lifetimes. That's significantly higher than the about 7% of the civilian population of whom experience PTSD within their lifetimes. Now, these high numbers have encouraged researchers to develop new ways in which to treat veterans with PTSD related to military trauma. So post-traumatic stress disorder is a psychiatric disorder that can occur in people who have experienced or witnessed a traumatic event such as natural disaster, serious accident, terrorist attack, war, combat, rape, or other violent personal assault. Military combat can include, but is not limited to, being shot at, being fired at with indirect fire, having your vehicle hit with an improvised explosive device, being exposed to casualties, situations in which an individual fears for their life due to these experiences. People with PTSD continue to have intense, disturbing thoughts and feelings related to their experience that last long after the traumatic event has ended. They might relive the event through flashbacks or nightmares. People with PTSD may avoid situations or people that remind them of the traumatic event, and they may have strong negative reactions to something as ordinary as a loud noise or accidental touch. They might seem jumpy, might have difficulty going into crowded places or situations that might be, something might happen that's unexpected. And we see that these struggles tend to impact many areas of their life: personal, social, occupational. And so there are trauma-focused specific treatment options available for veterans who have PTSD. This list can be found on the Veterans Affairs website. Cognitive processing therapy, prolonged exposure, and eye movement desensitization and reprocessing tend to be the most frequently cited and used, and that is because they have the most empirical validation for effectiveness for treating PTSD among veterans. However, there are other interventions that also have good use in veteran population and are frequently used, such as brief eclectic psychotherapy, narrative exposure therapy, written narrative exposure, and other cognitive behavioral therapies specifically to address PTSD. So we'll go over some of them. Cognitive processing therapy is based on the social cognitive model and really focuses on distorted cognitions and how those affect behavior. So faulty cognitions are going to be challenged to accommodate memories and beliefs. The standard is about 12 sessions, 60 to 90 minutes in length, and it's preferred to do it twice a week if possible. Might seem like 90 minutes is a long time, but it's a manualized procedure, and the sessions are pretty structured, so there's not a lot of room for tangents or outside content. The components include psychoeducation about PTSD in the process, understanding the relationship between thoughts and feelings and how those affect one another, developing the ability to identify and challenge cognitive distortions, and learning to accommodate the trauma experiences. So CPT, the usual format begins with a review of practice homework, followed by the content of that week's session, and then the last 15 minutes you go over the homework that will be assigned for the next week and any questions that might be had. Then one of the major components of cognitive processing therapy is the identification and processing of stuck points. So stuck points are these maladaptive beliefs that prevent recovery. And so what we want to do is we want to be able to identify these stuck points that are keeping this veteran from being able to move forward. And use Socratic questioning to challenge those stuck points. The stuck points could be thoughts or beliefs like bad things happen to bad people. So something bad happened to me, therefore I must be bad or I deserve something bad. Or beliefs that they're to blame for what happened or that the world is an unsafe place. And these beliefs are preventing them from being able to recover. And we want to teach them the skill, not just for us to do it, but for them to be able to challenge their own thoughts and develop new interpretations for their experiences. A narrative, written narrative, may or may not be used depending on the clinician and the client. And then in the later parts, in the later sessions of CPT, there are skills to be addressed to look at other areas of the veteran's life, such as safety, power, control, esteem, and intimacy issues. So the skills that they've learned, they can use them in these other areas of their life that have probably been affected by their PTSD. And then homework is a key component to the treatment. So hopefully they're going to go home and do their homework, but if they don't, then they bring the assignment back into the session. They complete it before they move on to the rest of the content for the session for that day. Prolonged exposure is based out of emotional processing therapy, and it's designed to help clients approach feared or avoided thoughts and memories, situations, or triggers. Also 12 sessions, 90 minutes in length, and it also has 4 components. So psychoeducation, again, talking about what is PTSD, how does it affect you, reading retraining to be able to help with physiology, imaginal exposure, and in vivo exposure. So the imaginal exposure is 30 to 45 minutes of the session is devoted to visiting and processing the trauma narrative. So, retelling in the session, and then often listening to the recording the veteran made while they're at home is part of this process as well. And we're working to diminish the fear response through extinction. The client and therapist collaboratively process the experience to allow the client to process and modify beliefs. And an interesting thing that is available now is that virtual reality is an option if you have the technology. Additionally, part of the process is in vivo exposure. And so PTSD often includes a lot of avoidant behavior of situations that are triggering. And so the individual will be asked to create a hierarchy of avoidance, situations that they tend to avoid. And it will go from perceived low risk to high risk. And we want the veteran to be able to focus on situations that are really important to them. And then we will ask them to conduct homework outside of the sessions where they can start working to address those low-level, low-risk situations and work themselves up. So, for example, a lot of people struggle with going to crowded places. So Walmart's really stressful. So we might ask them to start by going to Walgreens or something similar. It's smaller. Maybe it's going and sitting in the parking lot, and then go during hours in which there tend to not be a lot of people and kind of work their way up. So, slowly working them into these situations. Eye movement desensitization and reprocessing, EMDR, is typically one memory can be addressed in somewhere between 1 to 3 sessions. So the sessions depend on how many things need to be processed. It is an 8-phase process. So phase 1, we're really looking to make sure the individual is ready for treatment, ready to process any kind of trauma, and then gathering a very thorough history so we get a scope of what's going on, what memories we might want to target, and look at the ones that might be the most impairing or causing the most distress. In phase 2, we want to ensure that the client has the skills to reduce stress and handle strong emotions when they're in session. So we're learning stress reduction skills and imagery. In phases 3 through 6, that's when we really start getting into the process. We start processing targeted memories through the use of vivid imagery of the memory. And then, so while they're doing that, imagery, trying to remember that specific situation, they're also doing bilateral stimulation. So it could be moving fingers from one side of one's visual scope to the other, so back and forth, or it could be use of buzzers, so they'll have a buzzer in each hand, and so it'll buzz alternately. And as they do that recall. And then after the recall, the client is encouraged to tune into their thoughts, beliefs about themselves, emotions, and physiology. And depending on what the client reports to the therapist about the specific questions asked by the therapist will then direct the content of the next round of bilateral stimulation based on those answers. And the goal is that the memories can be recalled without distress, after being recalled over time, and that the client builds positive beliefs about themselves. In phase 7, we're moving more towards closure. Client to be asked to keep a log about any issues that might arise throughout the week. Looking at the skills that were learned in phase 2, stress reduction, and all that should be able to be seen at play, might be reinforced if necessary. And then phase 8 focuses on review and prepare for termination if appropriate. Really think about the progress that's made, and then what future considerations need to be made, or other areas that need to be continued for work or termination, depending on where that client is at. So with the 3 that we just discussed, CPT, prolonged exposure, and EMDR, these all require very specific training. You can't just go and do them. You have to have very specific skill training, development, and under some supervision to ensure that you conduct the therapy sessions correctly. Some additional interventions that are out and available if you're interested. A brief eclectic psychotherapy. So this is a combination of CBT and a psychodynamic approach, and typically is around 16 sessions, which is not always feasible. 16 sessions can be a bit lengthy and might be hard to get for insurance. It is a therapy in which you practice, they're going to learn relaxation skills, especially to be able to utilize the recall of the traumatic memory, be able to incorporate those relaxation skills, also practicing reframing negative thoughts about the trauma. They'll write a letter about their traumatic event, and then be able to hold a farewell ritual to leave that trauma in the past and be able to move forward. Narrative exposure therapy it's an oral narrative that covers the entire lifespan. By being able to cover the lifespan, individuals can understand how events have impacted their lives more fully. It can also help them identify any patterns that might exist in their thoughts and their behaviors. It is helpful, especially if an individual has multiple trauma experiences through their lifetime, so they can kind of use this as they're going through the whole narrative for their whole lifespan to address each trauma individually. It's a simpler way of engaging in exposure therapy. A written narrative exposure involves writing about the trauma during your sessions. Your provider would give you instructions on the writing assignment, and then allows you to complete the writing assignment alone. And then they would be able to return at the end of the session to briefly discuss any reactions that the individual might have to the writing assignment. So just kind of want to introduce you to some potential options for being able to work with veterans who have PTSD related to their military experience. There's a lot of good treatments out there and available that you can be trained in, things that you can do with your clients. Again, these are specifically trauma focused. There are other ones out there. If you would like to learn more, there are some references available to you, and I thank you for your time.